So, hi everyone. Like Olivia said, my name is Rohan. I am currently a CT2 in Northeast London for Nelft. I was working in Nelft before, and previously, before that, my first ever psych was a liaison psychiatry job, also in London. Uh, and this presentation is essentially a bit of my musings of what I wish I knew in my first job, but I've also spoken to a lot of IMG and UK graduates to try and create this presentation. Um, it's going to be very brief. I want to dedicate more time to answering any questions that people have. So we're going to sort of split it as 20 minutes of me presenting and 20 minutes of people having time to ask questions. In case you don't feel comfortable asking me questions here, I will pop my email down in the chat and you can just email me questions. That's not a particular issue for me. Like Olivia said, I'm in the BMA and I also hold a role in the Royal College as one of the members for the Resident Doctor Committee in the Royal College. And in the BMA, I'm an LNC member for my local trust in Elft. I'm transitioning to Nelft hopefully soon, but I haven't decided yet. And I'm also the conference agenda committee member for next year's Resident Doctors Conference. That's it about me. Let's get move on. So, what are the things to really consider before you start this job is basic things. Make sure you have a bank account, make sure you've got indemnity, make sure you've got BMA membership. I would highly recommend getting BMA membership, but this is really up to you. Consider if you want to have a work and personal number. Some people prefer having two SIM cards, one purely for work, one purely for personal stuff. That's entirely up to you. Make sure you have your accommodation, you sort out how you're going to travel to work, and if you need to drive, you get a driving license. Uh, what are the things you really need to know about working in psychiatry here in the UK? Is that the communication styles between people can be very different here compared to how it might be back home. Um, and we don't really have a hierarchical model of medicine here in the UK. It's a very much MDT model of working, which means we take in the opinions of everyone. So we'll talk a little bit about the MDT, and in psychiatry especially, the MDT is sort of the gold standard in the UK. You can't really do a lot for your patient without involving an MDT. A doctor itself is not going to make things happen. Um, what this leads to then is you have to collaborate quite a lot when you're working with people, and you really have to take into account how your tone sounds. Tone is everything in psychiatry, and tone, especially in working with colleagues in the UK, is everything. Uh, please be careful about how you actually say things. Don't react, respond. Take some time to think about what you say before you say it. Uh, Something that some of us tend to do when we come in here and we send an email is we start hassling people to reply. Please don't do that. Things can wait once you send an email. British humor can be very dry, so get used to it very quickly. Uh, Try and watch some British comedy. There are lots of comedy shows. Watch some British comedians. Go for some comedy shows so you get an idea of what British humor actually is. Um, and this is again a personal preference, but consider socializing with your work colleagues. This may inevitably be a pub, and some of you all may not want to drink alcohol. That's perfectly fine. You may not always want to go to a pub. That's also okay. But do consider how you can socialize with some of your work colleagues, especially since you've come to a new country and you really don't know a lot of people, perhaps. How to set up for your job. The only time where you really have to be persistent and probably haggling people is to make sure you got your IT access if there is an IT system in your hospital. Quite a few hospitals in the UK still rely on paper-based systems, so you won't need IT access there perhaps. Some trusts will have a mix of IT access for prescribing or notes, but paper charts for the other. And please attend the mandatory inductions. Those are legal obligations placed on trusts to make sure that they have given you what you need to know for your job. Now, coming to what you need to know for your job. The first things first, This is the bread and butter of your job, the Mental Health Act. There's a QR code on this slide that you can scan, and it should immediately download a blank Section 5.2 paper, which is otherwise known as a Form H1. In case the QR code doesn't work, you can also go on Google and just literally type in Form H1 Section 5.2. This is primarily the kind of Mental Health Act section that you might be using as an SHO or a new SAS doctor who's just come into the NHS. And what it exactly means is the Section 5.2 is a holding power to keep a patient in a hospital for up to 72 hours to facilitate a Mental Health Act assessment by a senior doctor. When you're considering putting someone on a Section 5.2, the most basic premise you need to have is you suspect that there is perhaps a mental health issue or there is an abject risk to the patient's safety, which requires an assessment under the Mental Health Act. So there's no harm in per se putting someone on a Section 5.2, but you need to be able to justify why you are putting someone on a Section 5.2. You can't just put someone on a Section 5.2 because you feel like it. You must justify why you are doing it. Sometimes when you are working in, and this is only in an inpatient ward setting, so if someone is in A&E, you cannot use a Section 5.2. It can only happen if they are on a bed. Sometimes when you're working, you might realize that you may not be able to reach the patient in time when the nurse calls you asking to consider Section 5.2. You are fully within your rights to ask nurses to issue what is called a Section 5.4. It is a holding power for nurses to hold patients inside the ward for 6 hours to facilitate an assessment for a Section 5.2, which is where you come in. The other two sections that you will most likely hear is a Section 2, which is a detention power to keep a patient for up to 28 days in a ward for the purpose of assessment of their mental health. You need two doctors to do this. It's not going to be you. It's most likely going to be an SPR or above, someone who is Section 12 approved. You need two doctors. One of them is independent and a social worker, and all three people have to agree that the patient meets the criteria for Section 2. You still need to keep a patient in the hospital. After that, you then have to issue what is called a Section 3. This would keep the patient in the hospital for 6 months. And again, you need a doctor and okay. All right. And a Section 3 is a detention power to keep a patient for 6 months in hospital. The important thing to remember for you is if a patient is on a Section 5.4 or a Section 5.2, you cannot force treatment on them under the Mental Health Act. You may consider forcing treatment on them under the aegis of the Mental Capacity Act if it's in their best interest or there's an abject risk to other people. But you can only do that in terms of a rapid trank protocol. In Section 2 and Section 3, you can forcefully treat a patient against their will. Right. The other section that you might have to deal with is called a Section 136. It lasts for 24 hours. It's a holding power utilized by the police to bring someone to a place of safety, which can either be a 136 suite or an A&E. These are people who are in public areas who are then brought into the hospital by police. The main thing that's important for you is you are not responsible as an SHO or a new doctor for their discharge. This is for the on-call SPR or someone who is Section 12 approved. The most important thing for you to recognize is that you might be asked to come and do an initial review of the patient, see if they can be assessed by a psychiatrist, because sometimes patients are intoxicated, sometimes patients have something organic going on, sometimes they might be unconscious. You will come and do an initial review and then let your seniors know who can then make a decision about what to do next. Now hi, right. The psychiatry MDT. Now, the psych MDT will be a wide variety of people, but usually what you will have are nurses, occupational therapists, psychology, social workers, and doctors. And what happens in a psych MDT is everyone gives their input and discusses to see how you can support a patient. So this would be if a patient is on a depot, when do you give the depot? How do you give the depot? Do you give it in the clinic? Do you give it at their house? What kind of frequency are we looking for? If they are living in accommodation, is it temporary accommodation? So medication, sometimes administration would come under nurses. Social workers would look at what kind of financial support does the patient need to remain well in the community? What kind of housing do they need in the community? What kind of extra support do they need in the community? Do they need care workers to come and encourage them to take their medication? Do they need support to, say, use a gym, start a course? So that will come under the purview of social workers. Occupational therapists would look at, can the patient manage their finances? Can the patient mobilize quite well? Can the patient do their daily activities of living? Can they cook? Can they clean? Can they move? Do they know how to take transport? Do they know how to cross the road? Can they cross the road safely? And then psychology would be, as you would expect, deciding if there is a particular kind of therapy that the patient requires. All of this not going to be done by a doctor, which is why you need all these other groups of workers to also join in the MDT. Now, I will be focusing quite a lot on the psychiatry MDT because this is a pitfall sometimes for doctors who are new to the NHS. I made the same mistakes, which is why I'm telling you. But before we get on to that, I just want to make a differentiation, at least on the most basic things that you need to know if you're a psychiatry SHO in an inpatient role and an outpatient role. If you're in an inpatient, you are responsible for clocking the patient. You are mostly managing things on the ward while your SPR and consultant will come and provide advice and just do an overall review of the patient. I've put the most common rapid tranq protocol that is used in all the inpatient wards, which is lorazepam. That is 1 to 2 milligrams at any given point of time with a maximum of 4 milligrams every 24 hours. You can either give it orally or IM. Promethazine is the other option of 25 to 50 milligrams, maximum of 100 in 24 hours, again, PO IM. If you are working in a liaison setting at any point of time, your emergency department might also use ketamine. And if you've exhausted lorazepam and promethazine, that's when you're thinking of haloperidol and olanzapine. The key point that surprises a lot of people when they come and start working in an inpatient role in psychiatry is that you are the only person who is medically trained in a ward. Your nurses are not medically trained, your psychologists are not medically trained, your HCAs are not medically trained, only you are. When you are working on call, you are probably the most senior medic. Your SPR doesn't know much about acute medicine. Your consultant definitely will not know much about acute physical health. You are the person, which also means if there is no phlebotomy service in your ward, you are the person taking bloods for the patient. You are the person doing the ECG for the patient. Your nurses can do blood pressure, vital signs, and everything else. They will do blood sugar monitoring and all of that, but you are doing bloods and ECG, and you are interpreting that. If you're covering on calls, what are you likely to be called for? Patient self-harm, you need to have a look at it. If there are physical health issues, Section 136 reviews, seclusion reviews. Seclusion is what we do in wards sometimes is when a patient is so agitated and so unwell that it is not safe to keep them in the ward, and we move them to an area which is sort of just a room with no bed, no furniture, no nothing, just a mattress. And there are cameras there, and you're constantly observing the patient. And you try and keep them there for as little time as possible. But that would be a special review called a seclusion review. There will be new admissions coming to your ward at any point of time. You have to go and you have to clock them in. You also have to do emergency medical reviews, again, if there are physical health issues. But what you need to understand in the psychiatry wards here, most psychiatry wards are not connected to physical health hospitals, and you don't have a lot of equipment. You won't have IVs, you won't have saline, you won't have IOs. Needles, you're not going to have any of that. If a patient needs something like even IV fluids, just because they're dehydrated, the patient needs to go to A&E. So if you can manage, think of the psychiatry setting as a GP surgery with even less resources than a GP surgery, and that's how you have to treat it. And if you're worried, you decide and you send the patient to A&E. Other jobs that you might do is prescribing medications. So nurses might call you saying a patient is complaining of headache, can you please prescribe paracetamol or something like that? And if there are paper charts, then it's correcting the drug charts in the ward. If you're doing an outpatient job, then you are reviewing the patient in the community. And this is what the bulk of psychiatry actually is. Like I'm currently doing a community job in CAMS, which is children and adolescent mental health. The most important thing that you will probably do in the community, besides liaising with other members of the MDT and seeing what input people need, is you are reviewing the patient from a medical perspective, you are planning the follow-up appointments for the patient, you are asking the GP to refer to other specialties if required, but you are prescribing medications on what we call FP10s, which is what we use in the community to give patients medication. It is not fair of you to always ask the GP to prescribe things for you. You need to take ownership of your patient, so prescribe things on FP10s. Now, most of you, like me, when you joined, may not know what an FP10 is. So I've given you all a QR code again, and FP10 you have to write quite a few things on the FP10, which is why I put the QR code there. The best practice of an FP10 is you give patients medications for 28 days. This is especially true for controlled medications, think ADHD medication, for example. In reality, it's really difficult for you to see patients every 28 days just because of the volume of patients that can be there in a caseload for a community team. So you may give up to 60, 90 days of medication to a patient, with the caveat being, of course, that it is safe to do so. If your patient has a suicidal risk or it tends to take overdoses, then you will not give them that much medication. I've put a list of helpful sites that I think would be really helpful for you when you start your job. The QR code is for a special site from the Netherlands. I'll talk about that in a second. The other helpful sites are download the BNF on your phone. You have guides both for adults and children. You have the NICE guidelines. You have the clinical knowledge summaries of the CKS. If you are going to start using FP10s, then you can't just write the dose. So say you want to give someone haloperidol 7.5 milligrams. There is no tablet of 7.5 milligrams of haloperidol. You have 5 milligrams, you have 1.5 milligrams, and you have 0.5 milligrams. How do you get to know that? You check the BNF and you check this other website, which is called the Electronic Medicines Compendium, which is used by a lot of pharmacists to know what medicine tablet formulations are available, and you have to prescribe accordingly. Another example would be you want to give someone aripiprazole 2 milligrams. There is no tablet of 2 milligrams. You only have an oral formulation, so you'll have to give 2 ml because 1 milligram in 1 ml. So you have to really think about that when you're prescribing an FP10. You can download the BMJ Best Practice, which is an excellent app. You can get something called Open Admins Access, which is available to every employee of the NHS. You can get it via the library, which is attached to your trust. The BMJ Best Practice has a lot of updated guidelines about physical health stuff, and it has what you call a comorbid calculator, which you can put multiple physical health issues together and then try and figure out a protocol to help treat your patient. The QR code is a website called PsychiatryNet. It is an excellent resource for you when you have to switch patients from one antipsychotic to another. It has a wonderful tool telling you how to cut the doses down from most of the common antipsychotics that we use here in the UK. It also has an antidepressant switch, but is not as great as the antipsychotic switch. The other important things for you to read. The Maudsley Prescribing Guidelines is sort of the Bible for prescribing in the UK. We all refer to the Maudsley Guidelines to figure out how to switch patients' medications, what to prescribe, what is first line, what is second line, and so on. The Fisher's Clinical Psychology is, again, just a very easy book to read, which is sort of talking about the signs and symptoms within psychiatry. The Oxford Handbook for Psychiatry is another useful tool, especially for someone starting their career in psychiatry. The ACB score checker is essentially a very good tool for you to use when you are dealing with patients who have delirium or old age psychiatry. The ACB score checker essentially asks you to input all the medications and it calculates the anticholinergic burden score on the patient. And if the score is quite high, it will make a recommendation to you to consider which medications can be taken out, because that might be contributing to a delirium or contributing to side effects that an old age patient might have. So think patients who are constantly falling down, for example. Uh, these are sort of what caught me off guard when I was working in psychiatry, which is nursing staff have no medical training. It's not a hierarchical model. The hierarchies are also quite different for staff groups. You have the ward or team manager for the other staff, but it's the consultant for the medical team. Uh, MDT input. There's a tendency, especially in psychiatry, that when things get difficult to just defer to the doctor. You have to be very careful with this because you don't want to overshadow the others by constantly just talking about things that you have no input in. So only provide input where it's relevant, because you might inadvertently be called condescending or rude almost just because you are talking because you think it is appropriate, but it may not be. So sometimes you have to learn how to hold your tongue. You have to remember to maintain boundaries. You can only do your job. Please do not try to do other people's job just because you are getting frustrated that things are not happening. You have handed something over to someone else to do, document it, follow it up, but don't try and do their job because people will then start dumping their work on you. And once you start allowing people to do that, it is very difficult to let that go until you sort of move a team and then when you can start afresh. Um, Sometimes it can be quite frustrating that people are not always direct with you and are indirectly telling you their opinion, which is very frustrating if you can't catch up on that. Right. These are just some websites that are available to everyone in terms of support. Practitioner Health is perhaps one of the best. It's available to all doctors. Uh, it is sort of separate from the NHS in a way. They might still have to tell your GP about it, but it's quite useful, and lots of doctors end up using this service. It primarily was built because of addiction in doctors, but it now helps with other mental health issues that doctors may face themselves. The Royal College of Psychiatrists also has a lot of resources. There's the Sick Doctors Trust. The BMA counseling, BMA also has a counseling service, and then there's the Doctor Support Network. Uh, so that's it from me. Um,